Good evening. Tonight we've got Jacq Allan as our guest speaker. Jacq is a clinical academic psychologist specialising in diabetes and has lived with type 1 since the early 2000s. In 2008, she founded the charity Diabetics with Eating Disorders, which focuses on providing support and advocacy in those living with type 1 and an eating disorder. This led to Jacq completing a research PhD in mental health and type 1 diabetes in 2019 at Birkbeck University, followed by training as a Doctor of Clinical Psychology at the Institute of Psychiatry, Psychology and Neuroscience at King's College London, focusing on diabetes psychology in both adults and children. She has also been involved with the STEADY project, which started in 2018, which stands for Safe Management of People with Type 1 Diabetes with Eating Disorder Study. This chat tonight, we're going to focus on different types of psychological therapies used in diabetes. But if you want to find out more about Jacq and her journey, as they say on certain programs, she was on an earlier diabetes chat where we discussed her diagnosis and different things, which was in May 2023, which you'll find on the Diabetes Chat website. So hello Jacq, and how are you?
It's Jacq, Philippa. No one calls me Jackie.
I know, and I keep trying to remember that.
People who do call me Jackie have to buy me drinks the next time that I see them.
I'm fine with that, Jacq,
because I haven't gone with Jackie since I was a very, very young child. I was getting in trouble, which is maybe why I have moved away from that.
Oh, well, that's like me if people call me Pip. I'm not a Pip or a Pippa. Can't be doing with it.
Right,
well,
but
not making
that's
by
how
me
I'm going to get you back then, Philip. I'm going to remember that.
So, as we are on a different format, I have no 90-second questions because you've already done your second questions.
Yeah.
And just discussing different types. So, I suppose one of the things that, just to sort of start it off, with the psychological therapies that are available, obviously you do focus on eating disorders, but it's not just people with disordered eating who necessarily would benefit from these therapies.
Yeah, and like I don't just focus on disordered eating. I have what's the word I'm looking for? Expanded since I started clinical training, mostly because I needed a bit of a break, I think, after the DWED years, and I absolutely find myself loving pediatrics. So I did a lot of pediatric work for diabetes. I was lucky to kind of swing it during my training, and then I spent practically a year in East Kent after I just about finished the doctorate, and now my NHS work is back in Tide at one of the pilot sites, but I work privately with people who have any sorts of issues with their diabetes, or people who want therapy who also happen to be type 1 diabetic, you know, and want someone who kind of has, it's interesting, I was speaking about this with someone the other day, that kind of like psychic understanding that comes from having type 1 diabetes and not feeling that you maybe need to explain some of that stuff. So I'm really passionate about therapy, specialist therapy, I should say, for people particularly with type 1 diabetes, although I do work with type 2 as well. But yeah, and what I've noticed, and certainly what I knew about myself when I was in a situation a long time ago where I needed therapy, is that I don't think that a lot of people really know what therapy is. And very often you sort of find yourself sitting across someone and they're spewing out these terms, and you're just kind of thinking, well, is it going to make me better? Is this what's actually going to help? And so one of the things that I wanted to do is to sort of talk a little bit about what therapy actually is and what it's based on in terms of clinical psychology. So if you see a specialist diabetes psychologist, chances are they're either going to be a clinical psychologist or a clinical health psychologist if you're seeing them through your diabetes team.
Mm-hmm.
And that means that there will be a number of models being used. And yeah, I guess I just wanted to chat a little bit about what the main models are. We don't have a massive amount of time today, and I know I used to be a lecturer, so this could run too long. But today I thought we might focus on three main ones, which is the one that everyone sort of knows about, which is cognitive behavioral therapy,
Mm-hmm.
and then two other forms of therapy that are quite common in diabetes psychology, which is compassion focused therapy and acceptance and commitment therapy. And if people have a good time in this chat, if they find it interesting, then maybe you could invite me back to speak about the other three. um, or also what that might look like in pediatrics. Like, so what sort of therapy do we use in pediatrics, or how do we modify it to use with children, young people, and transition young adults type thing?
Oh, that's really interesting. I suppose, and this is, I'm sort of not sure where this talk is going to go, so I haven't got a logical pattern anywhere here. So with you saying there being the three models, would people normally going to therapy, would it be, oh, well, I do this type, or would it be a bit of a mix and match?
Very much, and it very much depends on the service that you're under and what that service is commissioned for. So there are certain services, like for example, there might be specific tied services where the person doing the therapy there is only commissioned to give you up to 12 weeks of cognitive behavioral therapy, for example.
Mm-hmm.
So technically, they would be basing most of their work on that CBT model. Very few psychologists that I know actually do pure CBT.
Mm-hmm.
Because it's been so heavily informed by other models now. But generally speaking, if you go to a sort of clinical health psychologist, diabetes specialist psychologist, you tend to find that they use a bit more of a toolbox approach, which is
Mm-hmm.
sort of match the technique to the problem. I was really lucky to do part of my training with Rose Stewart, and that's very much the sort of things that we used to describe. I mean, obviously, sometimes you get a patient and you think, oh, I know exactly what the therapy is for this, and it's quite rigid to the model. But
Mm-hmm.
usually you sort of, it's more of a kind of whack-a-mole, at least for me, a bit of a whack-a-mole approach, depending on what the patient is coming in with.
So do you want to go through, or can you go through maybe what's the difference between the three types, or do you want to describe one type
Yeah,
in a go, just so?
I think it's probably worthwhile if you want to give me 10 minutes of non-stop speech. And
I'm quite happy to do that.
Yeah, and I'm quite happy for you to like ding the bell at 10 minutes when I start raving on about why tide services were terrible 5 years ago, which is a distinct possibility at around about the 10-minute mark.
Okay, I shall. Over to you for 10 minutes. I'll turn off my mic.
Okay. So probably the easiest model and the most common model to speak about is cognitive behavioral therapy. This is an approach to talking therapies that became very popular after psychodynamic psychoanalysis was deemed to be taking too long for short-term therapies, and there's a whole lot of reasons why cognitive behavioral therapy has become particularly popular. But the idea, the core idea, if you like, behind cognitive behavioral therapy is that how you think affects how you feel, how you behave, and the sort of outcomes that you have in your life. And those aspects become circular, so become what we call a maintenance cycle. So an example of that would be someone who has, say you've got type 1 diabetes and you're really socially anxious. And so you don't want to inject in front of anyone because you think that they're looking at you. So you maybe like get your pen out and you're going to try it, but you're behaving really strangely. So people are looking at you, right? So now you've got that maintenance cycle where your belief is kind of being propped up. Under cognitive behavioral therapy, there's sort of 3 levels of thought. The first level of thought are called automatic thoughts, and those are those sort of thoughts that kind of just like pop into your head. They tend to be relatively negative. Then the level of thought above that is your intermediate beliefs, which are kind of like your rules for seeing the world and your rules for moving through the world. And then you've got your core beliefs, which are sort of core beliefs about yourself, again, which tend to be quite negative. And these sort of interact. They get triggered constantly by your environment and by your everyday life. Now, the idea is that if you are distressed, or if you're really if you end up, say, like in a social anxiety paradigm, it's because your thinking is essentially faulty. And we can address that faulty thinking by using evidence. And very often that evidence is a change in behavior. So if anyone's had CBT, you might have done behavioral experiments, which is when, okay, you have this thought because you believe this thing, but your behavior, it might be actually maintaining those thoughts and beliefs. So if you can change your behavior, give yourself some new evidence, you can change that thought. So the main things about CBT is that there's a focus on the current situation. So you'll probably go into CBT, it's goal driven. There's a very specific thing that needs to be addressed, and you're not necessarily going to be dredging up your past. It's much more of a sort of current focused therapy, although there are certainly other ways of doing it using what's called longitudinal formulation, meaning that you might look a bit more into the past, but generally speaking, it's quite a what is bothering you today type of therapy. So it tends to be very structured, meaning that if you go to see someone for CBT, they have quite a distinct idea about what that therapy is going to look like over however many weeks you have it for. It's goal directed. And actually, the vast majority of the work that you're going to do in therapy isn't in the therapy session. There's a lot of activities, and I don't like calling it homework. I made the mistake of doing that in front of a young person once and then never did it again. There's a lot of activities that you might do in between that are based on challenging the faulty thoughts that you have, and therefore hopefully changing your behavior. So it tends to be very brief and time limited. I think normally you're looking at between 12 and 20 weeks. And yeah, part of the reason why it's become very popular is because it's being used by services such as an IAPT. If anyone's ever been to an IAPT service, which is now called Talking Therapies, it generates its own outcomes. So you go in, generally speaking, somebody will give you a survey and you say, I'm feeling like crap. And then in 3 months, they'll say, look, you don't feel as much like crap as you did 3 months ago. So it's sort of like an evidence generating machine for itself, which is part of the reason why it's so popular in the NHS. Okay, so that's cognitive behavioral therapy. So for Paul Gilbert, who is the originator of compassion-focused therapy, he noticed that there was a load of people who were doing CBT and it wasn't working for them. And he sort of decided that the reason for that is because these people who were doing CBT, they knew logically why they were doing the things that they did. They were sort of doing this homework and they weren't actually feeling any better about themselves. And he sort of decided that the reason for that is because they were being very harsh. They had this really horrible negative inner voice, the inner critic, if you will, and that's what was driving the distress. So Paul Gilbert originated compassion focused therapy, which aims to sort of look at what is motivating your behavior. So he believes that you can divide behaviors as being motivated by 3 main systems. One is the soothe system, which is when you feel safe and comforted, and that's all like the brain chemicals like oxytocin, opiates, naturally occurring opiates. Then you have the drive system, which is the system where you're looking for resources, which is related to dopamine. And then you have the threat system, which is obviously your adrenaline and your corticosteroids. So he maps this onto evolutionary neurobiology, and argues that we're designed to look for threat. Now, for those of you thinking that this might be particularly relevant in type 1 diabetes, where we have little things on our arms that go off every sort of 5 minutes and go threat, 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 you would be absolutely right. And that's why this is one of the main therapies that I use in people with type 1 diabetes. I always tend to bring in a bit of compassion focused therapy to my work, because the idea is here that in people who are like overly distressed, that threat system is dominating the worldview. So it's you're getting far more threat than you are getting driver soothe. And a lot of the therapy there is about learning how to soothe yourself better, and engaging in a different system that takes you out of threat and takes you out of panic. And that is what we call a third wave type of cognitive behavioral therapy. So it's related, but it's sort of adjacent, if you like. Then, sorry, I've only got 2 minutes left. The other one that you're going to see used quite a lot in clinical health psychology is acceptance and commitment therapy. And acceptance and commitment therapy is trying to get the patient to move to a place of psychological flexibility. And you do that via what's called the hexaflex. The hexaflex has 6 points that if you hit, then you should be able to be psychologically flexible. And that is contact with the present moment, having a committed action, knowing yourself as context, being able to cognitively diffuse, and having acceptance of what's going on around you. And my favorite part of this whole thing is knowing what your values are. So a lot of the work that I do is I try and connect patients with what's really important to them and what gives their life meaning, even if they're being physically compromised, which type 1 diabetes often does. So there's an opposite here, which is any of these 6 points can be opposite, and that's leading to psychological inflexibility. So you can be really stuck in the past, for example, rather than having contact with the present moment. You can have a total lack of knowing what you want in life, which then relates to struggling with your values, that sort of thing. So the therapy generally focuses on increasing those 6 points of the hexaflex through mindfulness, and also values work, and cognitive diffusion, which is being able to separate yourself from your thoughts. That's 10 minutes, and I feel like I've talked for an hour and a half. And I think that was probably really confusing for everyone.
Well, I'm
now
just
everyone's going to be like, clinical psychologists do what now?
so
A digestive biscuit? What is it? Okay.
exactly. So let me see if and you're going to say, oh no, and this is going to be dangerous because you know lots and I know nothing. So CBT,
yeah,
it's just trying to change the way you think about things that
Yep.
will help you cope with them, because you see them from a different direction. And so what you think to be the truth, you start considering, actually, I could be wrong and this could be happening instead.
Yeah, pretty much. I mean, that's probably the best way of putting it, is that it comes from faulty thinking. That your distress, whatever it may be, comes from faulty thinking, usually because you're thinking negatively. And it doesn't matter if it's OCD or panic disorder or depression or diabetes distress. It all stems from the idea that your thinking is faulty.
Yeah. No, that sounds good. And the compassion focused is that the person, it feels their innate, it's like primeval things, isn't it? They feel threatened, or that's overactive. And so you've got to learn a way to soothe that threat and separate yourself. Or am I wrong in this bit?
No, you're nearly there. It's not about separating yourself. It's about being compassionate for the brain that you didn't choose. So nobody, the way that we learn, we don't really have any choice about. and the things that we believe we don't have any choice about, and we're doing that in a brain that's primed to look for threat. And what that means is that a part of the way that we talk to ourselves is also threatening, right? So a lot of this, the way that comes, judgment, self-criticism, a harsh inner voice, comes from this sense of threat.
Yeah.
And if we can be compassionate to all the different parts of ourselves, then that means we spend less time in threat, and find it easier to soothe ourselves.
Okay, so yeah, and then I think I'm getting in now. This is where it crosses over for me with the acceptance and commitment. So that is more. Well, I'm trying to paraphrase it, and then I'm like, trying to find out where you are, what your beliefs are, and you may not know what, or it's hard to form where you are, accept where you are, and be where you are if you're not quite sure what's happening around you.
Yeah.
Or is that wrong?
Kind
That was
of.
the one I was a bit.
Sorry, yeah. So what? Do you know what? In my mind, I thought I'm going to have to do this as if it's a 2.5 hour lecture in 10 minutes. And listening to you talk back, I was like, yeah, that's a much better way than I actually put it.
No, do you know, it's one of those things that when I was listening to you, I was understanding it. Now I'm having to say it back. I'm like,
no, it's
where do compassion end? And
no, acceptance and commitment therapy is about accepting the world the way that it is.
Right.
And being able to connect through it via your values. And the idea is that your values don't change regardless of whether or not you're, struggling with disability or you're struggling with distress. So whereas CBT would say, no, we're going to sort of argue with that thought with rationality, acceptance and commitment therapy would say it's just a thought, it doesn't matter, it's not real.
Okay. No, that makes perfect sense. It's really interesting.
Yeah, I mean, this is the thing, everyone thinks that, if you don't know, therapy is therapy, but it's not actually. There's some real reasons why some people do get on with some therapies and don't get on with others. For example, neurodivergence. So
Yeah.
it's, and it's the techniques that each of these therapies sort of use, again, do really well with some people and really well with others. I absolutely love acceptance and commitment therapy, but you'll find you can throw me in a river before I'll do a mindfulness exercise because it doesn't work for my ADHD. But then I find other stuff for my ADHD that does work, that's mindful. So now I can bring myself back into that acceptance and commitment paradigm in a different way, if that makes sense.
Yeah, because it's sort of like, as you're saying this, they're like polar opposites, aren't they? So CBT is trying to get you to look at it from a different angle, paraphrasing a very short synopsis of it, and considering other views and that yours may not be the correct one, you're just assuming it. To actually, I'm accepting that I'm thinking that thought, but actually move on from it now.
Yeah, or I need to be far more compassionate in that thought because that thought was probably, oh my God, you're so stupid. But the thing is that they're all cognitive behavioral therapies, right? So ACT and CFT are what we call third wave cognitive behavioral therapies. So they all sort of come off the same root, which is this idea that thought is what governs what we do. And even acceptance and commitment therapy is about accepting thought, right? It's about letting the thought go, not letting the thought define you to a certain extent. So that's why there's still got that cognitive, because cognitive means thought.
Yeah.
That's why there's still cognitive behavioral therapies, even though they're not like, there's traditional CBT and then third waves, but they're still cognitive essentially in nature.
Yeah, just slightly not there. That's really interesting. And I did find it quite interesting when you were saying, 15 to 20 weeks. I think my local, or when I had CBT, I think it was 5 sessions.
Right. So this is the other thing as well. And I think we have to be really honest about this. What has happened is more and more people will commission you if you say, I can solve this problem in 6 weeks. And that's why you will find some services doing 6-week CBT. but realistically, if you're cognitive behavioral therapy is like 12 weeks for most things. That's what's commissioned in sort of primary care. And then you go up to sort of 20 and above if you're dealing with, eating disorders, for example.
Yes, yeah,
Because
yeah.
the other thing is to say that there are specific types of cognitive behavioral therapy for TIDE, for example. Like, so the STEADY project that I've been involved in, it has been looking at developing a specific TIDE CBT.
Mm-hmm.
And more, but ACT is the one that's becoming more and more used in health settings, and certainly that's the one that's taking off. But then I think we've sort of come to the age of just throwing stuff at the wall, seeing what sticks.
Yeah, and do that. No, that's really interesting, and that we spoke before this conversation, and I was sort of, I mean, I know I did CBT years and years ago, and then I did another course because I was like heading for burnout. And I was saying to you, I think it was more the compassion focused side of CBT that I had the second time, which worked a lot better for me. It's still rethinking about things, but actually, rather than immediately leaping to the fact that I've done it wrong, is actually, no, I did the best I could with the knowledge I had at that time.
Yeah.
And
Yeah,
it just
exactly.
didn't work.
Yeah, that's a very compassionate focused stance, because the thing about CFT is that a lot of people think that, oh, it's just being nicer to yourself. Well, actually, it's not, because change is hard. So typically what happens in CFT is that the reason that a change isn't being made is because there's something really quite deep underlying it. And so Paul Gilbert has this great thing that he says about compassion, which is that compassion is the sensitivity to suffering of ourselves and others and motivation to relieve it. So if you apply that to things like, I guess the way that I think about it is, it's not your fault, but it is your responsibility. And that is something that I would say to a lot of my compassion focused patients when they're ready to hear that. You don't start off a session by going, oh, it's your, it's not your fault, but it's your responsibility. But at some point, that's the sort of stance that you move to, which is that if you're truly being compassionate to yourself, then you can change. Because it's by not being compassionate that you're holding yourself in this threat pattern, and then that might be activating all these other things that you do. For example, drinking, or rage bolusing, or any of these sort of things that we do with our diabetes because we're kind of hiding from ourselves. That's where I would come in and want to take a sort of compassion focused stance on it.
And I suppose that's it, because a lot of those things are, I can't, well, again, I'm talking to a professional here, Jacq, and I'm thinking, so really it's like you feel under threat, whatever, I can't cope with this, so it's a way of a distraction or blinding out that threat, because you can't fight it or do it. So doing something else or getting rid of the threat, like you're saying, with like rage bolus for a high blood sugar, you're just trying to get rid of it then and there.
But it's about getting out of that threat as well, because I mean,
like fight and flight.
I don't mean to sound stupid when I say this, but threat is threatening. So, but I often think about this in relation to type 1 diabetes, because so much of what our lives are designed to be threatening. And I think that's even got worse since we've all been on this brand new spanking new technology. I used to be able to test 4 times a day, and between that it was like Schrodinger's diabetes. It was only 4 times a day that I was being told that I wasn't doing well enough. But suddenly I've got an alarm going off at 3 o'clock in the morning. I'm waking my partner up. What do I do in that moment? Do I just turn the alarm off so it doesn't wake him up, because that's going to give me an easier life? And then the next thing you know, I'm waking up and now I've got high blood sugar and I don't want to go to work. And can I make a clinical decision? But I have got to go to work. I've got to go to work. There's my threat system again, So I think for us, like, there's that thing that people say, oh, people with diabetes make an extra 180 decisions a day. I wonder how many of them are made under threat. Right? That's my question, is how many of those decisions are we making because we feel threatened, and the stuff that we wear is designed to make us feel threatened. The alarm's not a gentle little tinkle, is it? It's literally like death incoming. So
I have mine on vibrate, so
yeah,
mine's a gentle buzz.
yeah, yeah. So okay, well, I mean, I just feel that, like, I think if that works for you, that's great. But like for me, I'm like dead to the world, so it has to be on, like,
Yeah,
air raid siren. I mean, I've got a dog. I still don't even wake up with it like that. But but the funny thing is that actually when you start working with someone with type 1 diabetes, very often, because they're in that threat mode a lot of the time, they're like hanging on their last nerve. They're so close to burnout. And it's because
yeah,
and they really aren't being kind to themselves, but they're not even aware that they're not being kind to themselves. And
yeah.
that's why I really like CFT for a lot of people with type 1.
And I think, I mean, I can only say personally for this, I think the thing is for me that things will go wrong and I'll be blaming myself for, God, you
100%.
ruined that evening yourself.
Yeah.
You know,
So
why, why did you do that? That was stupid, and then that ruined it for your friends because,
yeah,
you're sort of saying, well, actually, I think I might have to go home. And they're like, oh, well, we'll come too. And,
yeah,
you think, no. But actually, when you logically think about it, it's, well, I hadn't done anything stupid. I had just done what I thought was right. And diabetes is like that at times, just didn't work.
yeah,
And then the best decision for me was to go home,
yeah,
which again was a sensible decision. But in doing that, I'm ruining the night for my friends, which is really awful. But do like, and it is just sort of,
but
for me,
that's interesting because you're demonstrating it in real time there, Philippa.
oh,
That cascade of negative voice of
yeah,
and then what very often happens is that, oh my god, if I hadn't gone to the gym yesterday, if I hadn't eaten this at 3 o'clock this morning in a hypo, and before you know it, you've got this massive long chain of shoulda woulda couldas,
yeah,
when actually what's happened is that you're diabetic.
yeah. And I
You
think I can't remember which one of, was it the exceptions one, that living in the present, it's as in, I can't do anything about what's happened earlier.
So now we're moving into ACT and acceptance and commitment
Yes.
therapy,
Yeah,
but
no,
yeah,
and I know I'm moving because I was thinking, I think this is the next one on. But
yeah,
I do think that at times it's like, well, actually, apart from maybe storing it, remembering it, learning it as a lesson, I can't actually do anything about what happened and has led me here. I've
yeah.
just got to deal with where I am at this moment and what's happening.
And actually, what we would do in acceptance and commitment therapy then is we would
Hmm.
look at that and we would say, when you did the right thing for yourself, when you took yourself out of that situation, even though it was disappointing, you did the difficult thing, right? So that's an acceptance of your current situation. What value were you engaging with that allowed you to do that? Do you have health as a value? Do you have being present for your family as a value? And then you were due to see them the next day. So it's sort of like thinking about everything in terms of values and in terms of meaning and what's important to you. And if it is okay, I felt like I wasn't being a good friend and being a good friend is a value to me, then how could you make it up to your friends? Could you send them something that they liked, or could you just send them a little meme thanking them for, you know, not
Mm,
making you feel awkward and keeping that. So if we were going to flip into acceptance and commitment therapy, what we would do is, like, say for example, the thought that came up there would be like, I'm a crap friend because I wasn't able to go out. Well, that's fusion with your thought, right? That's thinking that just because you think something, that's real.
mm.
How do we diffuse from that? We might do a mindfulness exercise, recognize that it's just a thought, it can't hurt you, and actually that you're engaging in a meaningful value, which is looking after your health.
And I suppose, and this is maybe my friends are thinking, yeah, she's really mean like that. She's never sent me anything after she's written it. Not that I've done it often at all. But my way of looking at it, I suppose, is going to a CBT thing. I'm thinking that they're thinking I'm an awful friend.
Aha. Now
But actually, if that,
you're in a negative thinking trap, Philippa. You're
but
what we call catastrophizing, and we're back in
but
CBT.
yeah. But actually, what I try and think of, actually, if that were the other way round, I would want my friend to be safe and where they
Yeah.
are. And actually, yeah, it might have not been the evening intended, but actually, there's very few evenings I wouldn't jettison
Yeah.
if it meant my friend being all right. And me thinking, oh, I'm ruining their evening because now they're coming home. Actually, if it'd been the other way round, could I have had a nice evening if I'm worried about my friend going home on their own and I know they're not well?
Yeah.
So I sort of think I, I look at that as CBT.
Well, I mean,
That rather than looking to they thinking, oh God, she's awful and we've now got to go home. Actually, it's not. It's that they're concerned about me
yeah.
and they want to check I'm safe.
Well, you'd look for the evidence. In CBT, you would look for the evidence. So you would say, okay, well, I went home tonight, but how many nights have I not gone home?
Yeah,
Well, if I'm thinking I'm a bad friend, how many times in the last month have I been a really good friend? You know, like, so there's evidence gathering for the thought.
yeah.
But what we would
And they
probably
still invite me
do,
out.
well, exactly. There's proof that it can't be that much of a pain to them if they've invited you back out. So there are all of these sort of different ways of thinking about these specific cognitive therapies, if you cognitive behavioral therapies, because they do
Hmm.
kind of all revolve around thought.
Yeah.
It's not an action. I think that's the thought, that's the behavior in the cognitive behavior. But yeah, so you can, depending on and this is, I guess this is a great thing about being a diabetes specialist, is that you pretty much get to use what we want, as long as it's evidence based, and as long as it's right for the patient.
Yeah.
And most of us, like I said, do sort of tend to take a more integrative approach. Yeah.
And I suppose having the knowledge of diabetes is really important because there's certain things where and I'm making this up. I'm not going to say this straight. I'm making this up. That maybe, oh, I don't know, if injecting in front of somebody was an issue because they're going to faint, do that. For something else, if it was like, oh, if I wear red, my friend doesn't like it and will faint. Well, you'd sort of think, do you need to wear red when you're with that friend? Is there a reason you need, sort of don't wear red? But you can't do that with sort of what are your alternatives?
Yeah, I think it's, do you mean like it's a benefit that I also have type 1? Because I think,
That the therapist has a knowledge of it. So there's
yeah,
certain circumstances
yeah.
where the logical thing, if you didn't know about diabetes, isn't what actually you need to do.
Yeah, and but I think having a knowledge of it is very, very important. But I think having personal knowledge of it can actually be a hampering, because sometimes I think it means that I make assumptions. So I find myself like always checking in now. If my patient would say, "Oh, you know what it's like, you have a hypo," and like, of course the instinct would be to like, "Oh yeah, of course I know what it's like to have a hypo," but you'd
Yeah,
never know what that actual patient means, and that's where I sort of find myself going, actually, this isn't this is a clinical conversation. It can be, and it can be quite
yeah,
difficult as someone who spends a lot of time around people with type 1 diabetes. You can sort of assume, which is
yes,
dangerous. But actually, I think that as I've gone on now, I'm more eager to double check than I was before, because I used to think that, oh, this is great, this means they've got a great therapeutic relationship with me, and then I made some really bad assumptions, and was like, oh god, I really should have checked that. I thought my type 1 was doing the work in the room for me, but it actually made me a worse therapist, if you like.
but I think everybody's experience of type 1, although we have a lot of things in common, we also have different we've had different experiences with it. And it's like people people's feelings on hyper and hypos
Yeah,
are
of
different.
course, yeah,
So
and
some
they
people
change
are
over the
like,
lifespan as well, Philippa. I mean, that's the thing.
yeah,
They change all the time. We all change all the time, and we all have very different experiences. I mean, it is quite nice in pediatrics when somebody might, I'm really scared about showing someone my insulin pump, and I go, okay, I'll show you mine. How does that make you feel?
yeah,
That's that's quite nice, and they're like, oh, it's not that bad. So that, like, it's quite handy in those situations. But in general, I just have to be maybe a bit more careful, actually, because
yeah.
because I've
But
been
at least you'll
community for
understand all the shortening
the
names,
jargon.
jargon and
Yeah,
stuff
yeah.
that we use. You won't need trying to explain. No, that doesn't do that.
Yeah.
I'm doing the opposite.
Also, it means that I know, especially when I was in pediatrics, when they were telling me porky pies. And I have had instances of them going, oh, I can't fool you, can I? And I'm like, nope. You leave that at the door, thank you. But yeah, I think, like I said, I think more of us are using these sort of integrated models. And there was a study done not too long ago about CBT therapists, where they went in and they looked at all of the skills and the way that they were interacting with their patients, and they found like virtually nobody was doing pure CBT.
Yeah. I mean, what I understand as pure CBT is, well, not hardcore, that sounds wrong, but it's a very methodical. Does that mean,
Right,
sort of?
it can definitely feel like that.
Yeah.
It can definitely feel like that, and I think there's a sort of way that there's a CBT stance. Like, I don't think I've said about like Socratic questioning, which is sort of, that's the thing that I think drives a lot of patients a bit mad, because you're sort of going, and why was that important, and why was that important, and what did that mean? And sometimes you get a patient going, why are you asking me all these stupid questions?
Make you think about it.
I know. And you're like, because you're
I've just got a hand up.
Yeah.
From Claire. Claire, have you got a question or something that's come in?
We've got a question from the community asking if ACT would be any good if a person's in denial and angry about having diabetes.
Yeah, probably. And that's ACT is something that I've used a lot for people who are newly diagnosed and adjusting to diagnosis. Yes.
And the other question that we've had is regarding only having 6 weeks of therapy. Would that do more harm than good?
Well, that that depends on the person having the therapy, and it depends on the issue being brought to therapy. I mean, and there's a lot of situations where actually, like, I have to be quite honest here, I'm a bit rubbish at discharging my patients. I like keeping them. And sometimes, I'll have someone say to me, I don't think I need to see you anymore. And I'm like, yeah, you're probably right. And you're probably right about 3 weeks ago. But so it's all very much depends on who's doing the therapy, on the type of therapy, and on the issue that's being brought in. Yeah, and in fact, there's some protocols are only 1 or 2 sessions.
Yeah, and I suppose that's it, isn't it? I suppose it depends what the issue is and whether you can do it. One of the things that, because you mentioned it like with CBT, and I'm assuming it might be for similar. So in all 3 of these models, you don't actually go back into, well, I'm going to say past trauma, but what may have developed the behaviours.
Yeah. Well, yeah, no, you can do, but it's not that sort of, it's not, I guess I sort of said that to sort of, to remove it away from what came before, which was very heavy psychoanalysis, which you could be in for years, and it had this stance where very much the therapist did nothing and everything was supposed to be unconscious, and you need to bring that out into the conscious. And I should say I actually really like psychoanalysis, and I like a lot of, even like Freud, I like a lot of that stuff, but that's it just wouldn't fly in the NHS these days. Can you imagine being in therapy for four years?
Yeah.
What ICB is going to commission that? I mean, I would love that. I'd never have to give my patients back, but
a long time to get over a needle therapy, needle fear as well. Yeah, I'll be able to inject in about 3.5 years, I think.
Yeah, but no, actually, in compassion focused therapy, we do a lot of sort of delving backwards, and I'll tell you what. Can I tell you one of the things that I say to? This is one of the stories that I tell most of the people who I do CFT with, and it's 100% true, and I use it to. This is one of the stories that I tell anchor the patient to the fact that they haven't chosen what they believe, how they've developed, what they've been traumatized by. when I was really young, I used to absolutely love baby chicks, right? I absolutely loved them, and I wanted one so badly. But I was also a bit naughty. So what used to happen is that my mum every week used to buy me an egg from the supermarket, and I had this fuzzy chicken, and it had these little felt pouches in it, and she would put this egg in the pouch, and she would tell me if I was a good girl, I would have a chick. And I never got a chick. And this went on for about 4 years until I was in primary school and I found out how chicks were actually born. And let me tell you, my entire worldview crashed down within one conversation with this teacher. And I had to go home, and my mum laughed about it, right? And to this day, she still laughs.
Mm-hmm.
To me, that's how you got a chick, because that's what I was told. And it was also tied up in what I did and what my behavior was like. I hadn't been a good enough girl that week to get my baby chick, so I would obviously modify my behavior because of my beliefs
Mm-hmm.
at a time when I wasn't old enough to know any better. And so I sort of think about that quite a lot in terms of how we grow up believing and behaving and what makes us feel threatened. So in compassion focused therapy, you might do a lot of parts work, which is like, right, so this is the angry part of you is coming up. What else? What other parts of you are coming up? Okay, the scared part of you is coming up. And we might think about, where does that come from? Where is that? Where did you learn this particular fear? Where did you learn this anger? And then we bring compassion to that. So that's very much when we go, the best you did at the time, right? Sort of that sort of stance, and reminding the patient that they didn't choose to grow up in a way that meant that they believed these things. It meant that those were the things that were internalized. But now that we know, now that we can be compassionate to ourselves, we can move that from a place of compassion into a place of action and doing something differently, which is that sensitivity to suffering and motivation to do something about it. So yeah, we might go back into it, but essentially you're looking at it to see what the effects are today. You're not really you're not delving into that in a way. But what I would say is that trauma focused CBT is one of my favorite forms of therapy. And I say that as someone who's had it. I've had trauma focused CBT.
Mm-hmm.
Focused on my particular issue, having lost a lot of people in my life. And it doesn't go back into, when I was 3 or my latent baby chick trauma. But it does go back into that incident over quite a lot of, or those incidences over quite a lot of detail. So you do touch on it, like, so the thing about you have a core belief about yourself, it tends to be pretty negative. So quite a common one in CBT is, I am unlovable. And so we might say, right, now that we've discovered that through Socratic questioning of what does this mean? What does this mean? It means I'm unlovable. Then we can see that all of these situations are triggering these negative automatic thoughts. So it's not necessarily true that we're not going back into the past, but we're not staying there, if you know what I mean.
So it's more what the past is, how it has affected you, than the actual, well, the past, but what's come from. And I suppose you saying what you're saying there, I think quite a lot of us, particularly if you were diagnosed a while ago, I hope it's better these days than it was.
Oh yeah.
I would say we are all traumatized from our old clinic appointments.
I mean, look, when I did CFT in a group, one of the modules that I designed was what to do when the negative voice in your head isn't yours.
Yeah.
Because I think a lot of us with type 1 specifically have that really iatrogenic trauma. And I have to say this, because it's not like people are going into work thinking, I'm going to traumatize my patient today. I mean, they don't know what you're bringing in. They don't know what nobody does. And I have absolutely, without a doubt, accidentally traumatized someone. I don't think you can be a healthcare worker and not accidentally traumatize someone.
But there's accidentally, and there's some of the things that have been said to me, which I don't believe are accidental.
No, look, absolutely. If I would ban one thing in the NHS, it'd be fear appeals. Or if you don't do X, then Y is going to happen. And
exactly.
especially
well, if you want to go blind and lose a leg, carry on.
Yeah.
Sort of thing.
I mean, like, and I would eliminate it from pediatrics, because I personally have seen so much trauma as a result of
I
those
think in
sort of
adults as well. I can't see that that's a healthy way. Even if it stops somebody doing something, it's for a really bad reason.
Yeah, and you don't. But the thing is that it might stop them doing that. But what else are they doing? Right?
Yeah.
Have they now developed an eating disorder? Are they now too afraid to eat? Because I mean, that's what I mean when I say I would ban it, because
it's traumatized them in a different way.
Exactly.
Got rid of one problem but started another.
Yeah, exactly. So I think a lot of, and again, this is what happens though, because if you're dealing with, say you're doing CBT, and your negative automatic thought is, oh, I'm going to go to clinic and they're going to tell me off, and then a clinical psychologist who doesn't understand the ins and outs of diabetes comes along and goes, well, what's the evidence for that? And then they go, well, they've been telling me off for the last 25 years. then that's where the model kind of falls apart. And that, I think that's why it's important that there are diabetes specialists who don't just understand diabetes, but understand the system and understand the historic system around us as patients, and all the way from pediatrics through to menopause and after.
And I can see that, because I can see if I at points have had a new consultant, and I will be honest, I'm waiting for them to trip up.
Yeah, you're waiting for the shoe to drop.
Yeah. And I'm sure, actually, and at times even I sort of think about it and I think, actually, no, what they've said is perfectly reasonable, but because of past ways that the same thing has been said in a negative way, do you know, like, it brings back the it's like triggering.
I mean,
they've not actually done anything wrong.
But that's the whole point of trauma, and that's something that this is the whole thing that I think trauma as a term has been trivialized. It's been trivialized by social media, and it's been trivialized by a lot of people not using it without really understanding what it means. But if we take it back to the purest form of meaning, trauma is a threat, right? Trauma is a threat to your life or your health. Immediate threat to life and health. So I'm sorry, but I'm traumatized every time my CGM goes off. Like, I live in a body that's inherently traumatic, as does everyone else with type 1, because we are forced with that. We're born into this disease with the knowledge that it can be fatal. So what that means is that we're automatically going to be on high alert. And if we then have these iatrogenic traumas where people say things to us that aren't great, then we carry that with us. And again, it's not your fault that your body and your mind react in that way. You didn't choose it. That is triggered.
Yeah. But what I'm meaning is that in some ways, I think now sometimes that it's that they've not said anything untoward as such. It's just my reaction to it is.
Yeah, but
so I would say I was carrying on being traumatized, but I'm not. It's me reliving a past trauma,
which is triggering, which is being triggered.
Yes,
but that's the whole point, isn't it? It can be the smell of the hospital. It can be pulling into the hospital car park. It can be the sound of the swing of the doors. You know, like, if you've had a situation where you've been in one of those medical environments and something has gone horribly wrong with your diabetes, a condition that can threaten your life, then of course the way that might go in terms of your brain is trauma. And that is something that I think that as healthcare professionals we have to accept that, and we have to accept that people are going to come in front of us and they're going to be on the back foot. They're going to be angry, they're going to be resentful, they're going to not want to speak to us. The very act of them being there can be re-traumatizing and triggering, which is again why I think diabetes psychology is so important, because when we sit in the team, one of the things that we're sort of doing is going, oh, can we have trauma-informed care? And we're talking about trauma and all of those sort of things.
So within your area that you work in the NHS, do you also have sessions with the clinicians that they somehow, I'm not saying they're going to go in depth or anything like that, but find out, or that they ask people, or do you know what I mean, how they should act to people?
Yeah, I did one last week, Philippa, of course.
Oh, Jackie, I knew you would.
Of course, I did. Yeah, and like me and one of my friends who I was very lucky to train under Rose with, we did these little videos of us interviewing each other, and one was like totally traumatic. In fact, she started off by calling me Jackie, Philippa. And then dismissed me when I said it's Jack, actually. And
I'll start calling you Jacq Allan.
That's all right. I'm only messing with you. But that was how we started the video, because the idea is if you if you start off by even dismissing someone's name just by going whatever, then then that's very likely replicating other relationships that have been traumatic in that patient's life, including with potentially old school paternalistic diabetes consultants. So again, but we have to take a compassion focused stance to everyone, right? Or there's a new way of doing this. It's called trauma informed, which moves the conversation from what's wrong with you to what happened to you. And so that's sort of where we're trying to start all of these conversations with our diabetes patients.
And I think that's I think that's what, with my own experience, but I'm obviously only speaking as n equals 1, from having a very traumatic relationship initially to now with a really nice clinic. And I'm, like I say, occasionally something might be said, but it's not intentional and it's me, not them. But it is this change of focus. And I think with it being a long-term condition, it's sort of ongoing, is what do I need? So it doesn't mean that they don't have input if they think something's going awry, but it's what's important to me at this time.
Well, I mean, like,
changes the conversation.
Yeah, weighing people is the big one for me, because you can sort of and having those conversations. I mean, like, we've been having conversations recently. Like, what do we do when we actually do need someone's weight? Like, how do we have that trauma-informed conversation with them, saying, I know it's really difficult for you, but this is an eating disorder clinic, so we need your weight. And sort of ways of having those conversations that don't re-traumatize or trigger someone. So,
but it is that they just do it at every appointment. Well, not now because the telephone.
Flipper, we've got a hand up from Gary. I don't know if he's got a question.
Okay.
Gary?
Hi guys. I just want to jump in. First, I want to say, Jack, I am so glad that you discussed about ADHD and neurodivergent conditions and CBT and its role in it in terms of how they work for some people, because for me, cognitive behavioural therapy just didn't work, and I went through a situation not that long ago where I went to a really dark place and tried some things that I probably shouldn't have done to make things easier for me, not thinking about other people. So I'm happy that you've discussed that, because it really is something. I think that everybody thinks CBT can be used for everybody, but not everybody can use CBT, or not everybody can use certain parts of CBT. Mindfulness for me just doesn't work. They taught me to put my thoughts in leaves and send it away. I ended up backlogged with negative thoughts that all ended up coming back at the same time and hurting me more than that. But the one thing I want to say is, we're talking about the change in diabetic clinics, specifically with clinicians, and how they now approach things and how they now say things, rather than that. Because I grew up in the era that Flipper's talking about, where I used to get sat in a room and told, if you don't do this better, you'll be blind, you'll get neuropathy, you'll lose your legs, you'll lose your vision. And I've ended up getting all these things that they scared me with, because what they were doing never worked for me. It never helped
backfired.
Me. But my biggest thing with this is, it's not just clinicians that need to be taught this. I still walk into a doctor's surgery and I'm triggered, because it's all about, they put anything I go on with, they bring it negativity. Or that's because your diabetes has caused that. And so primary care, because ultimately my GP is called primary care, and alongside my diabetes being called primary care as well, so my specialist. But my GP, because of where I live in Scotland, my GP is my first port of call before I phone for a diabetic specialist doctor, which I find very confusing, because I'm phoning specifically about a diabetic related incident, but I need to phone my GP, who then needs to phone my specialist, who then phones me. But we'll not get into that. But my GP triggers me every time I walk in. So today I went into a GP appointment because I'm on a medication for my neuropathy where there's risk of retention of fluid. And I started noticing in my hands and feet that my hands were getting very big. And I'm like, I can't see my knuckles. What the hell's going on? Then I looked at my ankles and I was like, actually, where are my ankles? So I phoned my doctor and I says, look, I was told to inform you if I've got any swelling. They says, can you come in at 2:00? And then the first word they walked into the door is, how much exercise do you do, Gary? Because it will really help you with your diabetes. And I'm like, I'm here for swelling in my feet and hands because of pill. And you've just told me how much exercise are you doing, which ultimately is basically a roundabout way of saying, Gary, I'm looking at you and you look fat and you need to lose some weight. And it triggered me, and then I became defensive. I was like, well, I can't do as much exercise as I would like to do because, trying to walk or trying to run or trying to do anything when neuropathy is not easy, when it's like unbearable pain running through your legs. So there has to be as well, I feel, even though we're getting clinicians to change their attitude, somebody has to speak to doctors as well, because we're still in a circle where some people are getting treated that way and we're circling around in the negatives there. And then the clinicians trying their best to help. But when I'm speaking to the clinician, I'm antsy because my doctor's already flared me up about the problem that I'm phoning for, and then take me into an appointment and make it about another problem. So I'm already in a stage of anger and upset and a traumatic experience that my doctors created for me that was never part of the problem to start with, if you know what I mean. So I feel like we need to get GPs in there.
You are literally describing the trauma cycle almost there, Gary, which is that you're going in and they've said something that's put you on the back foot immediately, because actually what you're talking about to me, when I hear that, it sounds like they've initially just immediately dismissed you. And I don't know if you're anything like me. The only person who gets to dismiss me is my diabetes consultant, and he's only had that because I've been with him for over 20 years. And even then he pisses me off sometimes. So
and I've got a great relationship with my diabetic consultant, which I'm sure you've got, because I've had the same one now for over 30 years now. So I remember seeing him as it was, for some reason, he remained my consultant into adulthood as well. So I seen him as a child, then he remained into adulthood. So I've had the same consultant the whole way along, which has gave me that luckiness that I built a good bond with him. So he is the only person that gets to criticise me, but when he criticises me, also gets my vocal opinion on it, saying, well, actually, no, you can't, you have the right to say it, but I think you need to say it in a better tone to me, because if the tone doesn't change, I'm not going to listen to what you're telling me. So we've built this relationship where he knows how to criticise me without pushing at me and making me go into a traumatic experience. But my doctor doesn't have that right to criticise me. The only person that has that right when I'm sitting in that doctor's surgery is myself. If you know what I mean.
I do, and I think maybe one of the things that I might advise, I guess, and I'm saying this in a general sense because obviously I can't give like quote unquote clinical advice, is to think about what's safe for you to say, like what allows you to calm down, what allows you to be able to take a step back from that. So it might be something along the lines of, oh, did you speak to my diabetes consultant?
Yeah.
Or something that puts the power where you're comfortable with it being, something that maybe allows you to feel a little bit of that control back. What's quite disappointing is that Scotland, and I'm up here as well at the moment, but Scotland is supposed to be the number one in trauma-informed care. so maybe,
I'm sorry, but
maybe you want to tell them to take a look at the guidelines.
Yeah, I have to disagree with the trauma because I won't say what I'd done, but I ended up in hospital with what happened, and my diabetic team never even came to see me to discuss what was going on or anything, and it was a diabetic related problem that caused it, and nobody from my team came to see me to see why it happened or what was happening. I was left with an A&E doctor that never really understood diabetes. They only had the bare minimum understanding of it, and they never knew how a pump worked. So requested that I take pump off and go without. And I was like, but then I can't. And they're like, well, you better take it off, or we're taking it off you. So I lost a pump because, in fairness, it probably should have been off, but I lost a pump because nobody understood it and nobody thought to call a diabetic specialist down to come and speak to me about what was happening. And I think that even although Scotland say they're the best at it potentially, and the statistics show that, it's not ultimately very true in some cases, in some cases where you probably would have needed a specialist to speak to. And I feel like you're talking about the CBT and the training. I was offered CBT and I took it. They done me a 6 week. They wrapped me up in 6 weeks, and nobody ever followed up with me. But what they done was ultimately told me to put my problems in a leaf and send it down a river. And the river ended up backlogged with all my leaves, and my leaves came tumbling back. And it wasn't just one leaf; it was like 100,000 leaves. It felt like, and all the problems just came tumbling back. And I was like, "Oh my god, I don't know how to fix this, and I can't. I don't know what I'm doing." And I think that's where there is a need for a better approach in some areas. Because in Glasgow, if I was in Glasgow, I'd probably get a 12-week session, but because I live in Ayrshire, I'm only entitled to a 6-week session.
Gary, I know this is really important, and I hate to do this.
Oh, sorry.
Can I just leave that just for a little bit, because we're getting towards the end of our time?
Sorry, Flipper, I'll shut up then.
Sorry, and I know that Thomas messaged that there are some other questions that I'm hoping Claire's got, because I'm just on my phone at the moment and I just can't cope doing everything just off my phone, because I usually cut off.
Can I just say a little something about that, which is that I can, Gary, I can well believe it. What I would say is that I think in general, diabetes psychology is a bit better in England than it is in Scotland, unless you're in Grampian. Grampian have a really massive diabetes psychology department led by Kirsty McLennan, I think is her name off the top of my head. I think she's on Twitter, I'm not sure. I'm sure she won't mind me saying that because she's spoken about it quite publicly, I think. But I think that, Scotland in general, they're not quite up to the levels of having specialist psychologists as they are in England. I mean, in England, we've got Tide clinics now, which is, again, something that Scotland is a little bit behind on. But I think I know this isn't fair, and this isn't something that should be put on to patients, but we need to maybe organise a bit as a community and almost demand specialist psychology from our commissioners, which is very difficult when the same people who demand it are also knackered and burnt out. And I understand how difficult that is. And, this is something I've been campaigning for years, and we're only sort of really starting to see now the fruits of that. So yeah, I can well believe it, and I'm really sorry that happened to you. And if it makes you feel any better, I did the leaves on the stream too, and I was like, no, I don't have a leaf. I've got ADHD. I've got a forest. It's a forest in the stream, and it's going 800 miles an hour. And this isn't going to work for me. But the funny thing is that you do it with some patients, or I always broach mindfulness and that sort of stuff very carefully with patients. And for some people, it really works really well. So having that really personalized specialist approach is what it's all about, I think.
Yeah. Oh, yes. And as I say, Gary, it doesn't sound right what happened at all. Now, I'm going to maybe drop Claire in it. I'm not sure. But did you have some more questions from people?
Linda has made a comment saying, isn't living with type 1 diabetes just 24/7 threats?
Yes.
Delayed digestion is like playing Russian roulette with insulin, but CBT hasn't helped. Moved on to a liquid diet, and that's making her eating more disordered. Anna from Canada has commented, being told after DKA as a teen and a week in hospital, her endo told her that she'd be dead at 40. Ouch. Tempe has commented, the drive into the car park was a huge trigger for him, but his DSN has completely turned that around by being amazing compared to the consultant, who offered no support. We've had the comments saying that there was a gentleman diagnosed in Cornwall and only had one resource group, which was lots of kids with disabilities. Has there been any change and better resources over 16 years later?
I mean, I hope so. I mean, like, what I would say is that those of us who are diabetes specialists tend to be really passionate about it. I mean, I know where I work, I've been in post for less than 4 months, and the girl who's in the adult diabetes as the psychologist there, she's quite new in post, and we're both like, give us trainees, you know, let us get people excited about this as a specialism. But more than anything else, the thing with most diabetes psychology is the funding actually has to come from the medical side of things, and that can be really tough. So we're not affiliated with adult mental health. We're actually with the diabetes team, and so you'll see, like, I know certain psychologists have made their own business cases and taken those to diabetes consultants and gone, like, find me a job, you know, give me a job, and certainly that's the sort of, we shouldn't have to do that, you know, like, because my argument is that we don't know who's going to get retinopathy, we don't know who's going to get neuropathy or gastroparesis, but I'll tell you 100% of people with type 1 diabetes will get diabetes specific distress at some point. So why are we a nice to have? Like, surely we are as essential as anyone else on the team. So I do think that it is getting better. I think it's definitely better in pediatrics than it was before. And yeah, I suppose, like, for me, one of my passions is getting other people involved in diabetes psychology. And it's the thing about diabetes psychology is it's really exciting, it's really nimble. There's new research coming out all the time. You know, one of my groups that I'm going to be running in my NHS clinic was based on someone's doctoral research last year. You know, it's a really cool, fast-paced type of discipline, and you make real difference to people, you know, and you get to see that difference. And very often, like, you know, you'll have your patients with you for a while, and if you're anything like me, you don't want to give them up, which isn't great. But yeah, I think and I hope that things are improving. I think we're definitely seeing more research. We're seeing I think charities like Diabetes UK and JDRF are more up for mental health and diabetes care than ever. My worry is that people think that closed loop is going to solve everything. And for me, as an eating disorder, like someone who really specializes in Tide, I think that they're creating a lot of problems as well as solving them. And we are, you know, sort of, it's an experiment. We had no idea what was going to do to people psychologically to make their blood glucose available to them 24 hours of a day, 7 days a week, you know. I think that there needs to be more psychologists in NHS England making decisions, and it's quite obvious. You look at some projects and you think there's not been a psychologist anywhere near this, and that really, that I think is the next step for diabetes psychology, I think. Sorry, that's my bit of a rant. That's my high horse.
Oh no, there are quite a few comments. I've been trying to look at them, but I'm on a small screen, so sorry. And there's quite a few sort of agreeing with the different trauma, and there's one from, sorry, I've gone past it and my screen's jumping about. It was from a doctor saying that agreed that you've got to build a relationship with somebody before you can expect honesty and trust and things. There's a couple of questions about, would ACT be helpful if I'm dealing with anger and denial about having diabetes rather than CBT?
Well, I mean, I think it depends on what sort of thinker you are, and what sort of thing moves you and motivates you, to be honest, because coming to terms with diabetes is a process. Oh, God, I can't believe I just said that. That made me sound like a psychologist. I'm sorry. But there is a process, and I think there's a natural process to that. And so the question would be, you know, my first question would be like, well, how long have you had type 1 for? Because if it's within the first 6 months to sort of year, I would expect people to be pissed off, angry, and kind of in denial. Like, that's a sort of natural and just because, listen, when I say natural, I don't mean easy. Because like sometimes
No.
when I say, oh, that's normal, people think, oh, that means that it's easy. It's not easy. Getting diagnosed with type 1 diabetes is never easy, but it is natural to be angry and in denial for a while after diagnosis. If you feel, however, that this is now getting in the way of things, that actually you've gone past that you would have thought would have been natural, and now that this anger and denial is getting in the way of you having a fulfilled life, if you sort of have a good idea of what's meaningful to you, then yeah, there's nothing to say that ACT wouldn't be a good fit. But then it depends on the sort of thoughts that you're having around it. If you saw a specialist psychologist, what I haven't done here is actually talk about what specialist psychologists would do, or what any clinical psychologist would do, which is that they would go and give you a kind of semi-structured, usually clinical interview, and do what's called a formulation. And a formulation is what we do instead of sort of diagnosing, usually, where we have hypotheses about what's causing the issues with the behavior that you want to change, or the beliefs that you want to change, and then we would come up with some sort of ideas of how we might be able to help, and we do that all together. The formulation is something that's fluid, that moves, that you would share with the patient or with whoever you were working with, to say, does this sound right? Have I missed anything? Are there important factors that might be useful when we're planning treatment? And please bear in mind, today I've only spoken about 3 therapies that might be used. There's loads of others. There's dialectical behavioral, there's cognitive analytic, which is a bit psychodynamic, but I think is quite useful in diabetes as well. And then there's my favorite thing that I use with kids, which is narrative therapy, which is about—
That's really good. You've answered somebody's question there.
Okay. And then
That's what I was just about to say, because that's what I was going to ask next.
Yeah, and then on top of that, there's solution focused therapy. There's EMDR for trauma. There's so many sort of different therapies. I just want you to speak about those 3 today, because they're the main ones that I use in adults. But actually, I haven't talked about dialectical behavioral therapy, which is for emotional regulation, which is something that I've used with a lot of patients who have type 1 diabetes. And like I said, my favorite for kids is narrative. If any of you saw me on Twitter looking for a Dexcom that I could put on Mario, then you'll know why. You'll know why narrative is my favorite for working with kids, because you get to retell, they get to retell their story, and think about what their strengths are and stuff. So, so there's loads of different therapies, and most of these are like the more sort of up to date ones. We're not even talking about like sort of person centered or more sort of counseling psychology models, and more sort of psychoanalytic psychotherapies as well. So I don't want you to be limited by these 3 things that I've been—
Oh, no. I find it quite interesting with you saying about how long somebody was diagnosed, etc., etc. I remember it was quite a few years after I'd been diagnosed, and I think it was on a work course, because the cycle of change is very similar to the cycle of grief.
It is.
They say the stages you go through, and I was sat there going through the cycle of change, and I could have I was just thinking, oh my God, I never realised I'd done that with my diabetes.
Yeah, and do you know what? I almost think that recognising it as a grief cycle is really important for parents of type 1 diabetic children. Like, and they're allowed to grieve. They're allowed to grieve the life that they expected, that type 1 diabetes has come along and sort of kicked over. And not too long ago, I was thinking about doing something like designing a parenting intervention based on the stages of grief, because they're a bit more dynamic. I think the stages are more dynamic than linear. But yeah, I think it is very similar to having that grieving process. And of course, what happens when you're first diagnosed is you're bombarded. So you don't have time to grieve. You don't have time to process or accept.
You just survive it.
Do, which is not too dissimilar to what happens when someone dies. You don't really get to grieve. You don't get to process. You've got all of this stuff to do. And I think that's very similar to what happens when you get diagnosed with type 1 diabetes. Maybe more as an adult than a child, because you're the person that has to sort of sort that out. But I think, yeah, definitely.
I'll add that to my mantra, because I know we discussed it last time, me saying that the sort of mental side, diabetes, distress, and burnout should be mentioned to everybody as a side effect.
Absolutely.
Diagnosis.
It's a complication.
They
It
know to
annoys me.
expect it. Yes,
It annoys me
yeah.
that we don't see it. We don't talk, you know, like you go and you see like, oh, what are all these things that you might get with diabetes? And I'm like,
Exactly.
you might get distressed. That's like
Yes. In fact, you're very likely
you
to.
might get pissed off, angry, and upset that a whole organ no longer works. And you're definitely going to get that before you get retinopathy, let's be honest.
Yeah.
So
But
yeah,
maybe
I mean,
we should warn people about the sort of like the grieving of the life that you thought you'd have, but you haven't now, or what's been added to your life that you didn't particularly
and
want.
also the trauma. I mean, like half of us are diagnosed in DKA with blood sugars in the 50s. Like that is inherently traumatic, and especially when you see this in parents of type 1 kids whose kids have been rushed into the hospital, and then of course they've got literal PTSD, but we're just going, oh, look at the time and range. Like sorry, I mean, obviously there's a lot of crossover here and there's a lot of hats that I'm wearing. What I will say is that I think as a workforce, and I am speaking generally, but I have worked across a few diabetes clinics now. I think that as a workforce, diabetes clinicians are far more psychologically informed than they ever have been. I know certainly in some of my MDTs, I sort of sit here thinking, wow, you know, like this, I couldn't have imagined having these conversations 10 years ago. And certainly in my pediatric jobs, people would come in and be like, oh, they're really complicated situations, and like really thinking about things in a nuanced way. So I think that things are changing for the better. Obviously, this is a difficult hat for me because I work for the NHS and I love the NHS and I'm reliant on the NHS, and I'm also significantly traumatized by the NHS and I'm a member of this community, and before that I was a patient advocate. So I don't, you know, I hope I haven't offended anyone by anything that I've said tonight. That certainly wasn't my intention. Because I really do think that things are changing for the better, albeit slowly. And you know, I hope nobody's thinking, right, I'm not giving her a job in 18 months when this pilot goes down the drain.
It's been really interesting actually hearing the different types, and in myself recognizing some of the different types that obviously I've sort of received at different points for bits, which is sort of really useful. Now, just one question that just springs up in my mind: if your area is only offering CBT, which does happen, is there any way to get the other types of therapy within the NHS? Or
I think you don't. I think I don't get. Don't ask, don't get. Right. So the first thing is, like I said, like most people who this research shows that most people who are doing CBT aren't doing pure CBT.
Yeah.
And I think it's always worthwhile going and see it, because the other thing is that CBT gets a bad rap. And I think CBT gets a bad rap because of this that's happened, right? Which is that that's all we're going to offer. And of course, for the people who didn't get on with it, they were quite vocal about it, rightly so, because we would do the same thing if it was a drug. If we were all like, you know, FIASP, I hate FIASP, it doesn't work for me. I tell everyone that I hate FIASP, right? Because it you know, it really annoyed me. It worked for 3 days and then I was in DKA for a week, right?
Yeah.
But you know, like my best friend loved FIASP, and you don't hear her going on Twitter, I love FIASP. But the time and range is like constantly 85%.
Got a bumper sticker probably.
No, but there's at least 25 posts of me going like, screw you guys, you know. So CBT does get a bad rap, and I think that hopefully more people realize that, more CBT therapists realize now that it's not for everyone. I think they probably do. So it's worthwhile still going and then saying, maybe this isn't working for me, and I would like something different. Would be my initial sort of recommendation. And the other thing is that, and I hate to, oh gosh, I have to say this because I do also have a private business where I do private psychology. And there are a number of private clinical psychologists now who specialize in diabetes. And I think if it might be worthwhile if you're sort of going through these services and not getting what you want and you can afford it, it might be worthwhile trying to find someone privately. But that would never be my first stop as someone who works for the NHS, obviously. But but I think there are
it's
more
also knowing that you are properly qualified, and do you know what I mean? Checking out
don't
people
get me started on the charlatans.
Exactly.
But we'll be here. That's a fiasp post for the future. But yeah, I would look. There's a lot of ways that someone can work with you therapeutically. But probably the most important thing would be to look for someone who has a regulatory body. So if you're a clinical or a counselling doctor of psychology, then you're registered with the Healthcare Professions Council. Then there are other sort of forms of counselling that you can get qualified in, and that will usually be under UKCP, which is it's either UKCP or UKPC, which is the United Kingdom Council of Psychotherapists, Council of Psychotherapists, I think. And the other one is the BABCP, which is the British Association of. See, this is the problem. I only know my own regulatory body.
Yes, yeah.
But I think it's BABCP. So you need to check that whoever you're working with has a regulatory body, because therapist is not a protected title.
Yeah.
So psychologist isn't a protected title either.
Oh.
No, clinical psychologist is, health psychologist is, forensic psychologist is, counselling psychologist is. All of those require doctorate.
Oh.
Yeah, so those are protected titles.
I thought it'd be like doctor. Do you know?
Oh no, absolutely
like medical
not.
Doctor.
Well, no, the HCPC registered are there, so like there's some that you have to have a doctorate for, and they're protected. So forensic, health, clinical, and counselling psychologist, doctors, they all have doctorates attached to them. Apart from forensics, which you can do another route, but it's still a protected title. You have to have very specific qualifications for that. But literally anyone can call themselves a counsellor or a therapist, which I personally think is horribly dangerous, and we need to regulate as soon as possible. Because how do you know the ones who are registered with BABCP, the ones who aren't? I would check things like do they have a master's degree? Do they have all their counselling levels? It's a bit of a minefield, to be honest.
Yeah, and I was going to say, if they are registered with the official bodies and that, you have some form of comeback if there was ever anything. I'm not saying it would happen, but do you know?
No, absolutely. And a good next question is, do you have indemnity insurance?
Yeah.
Because if you don't have indemnity insurance, you can probably disappear into the night. But no, I obviously I'm biased. I think that clinical psychologists and counselling psychologists, we have quite similar trainings. We have to do a lot of different rotations in the same way that a doctor does rotations. We tend to be we've trained across loads of different areas. The average time it takes to become a clinical psychologist from when you start your undergraduate is 10 years.
Oh my goodness.
So I mean that's why for me, when I see my therapist is a clinical psychologist.
Yeah. No, that's really important. But I just thought I ought to put that out there, because I do know there are unregulated people around, and
send them to me if you want me to check them out. If you come across anyone who's doing like diabetes therapy and you're like, Jacq, does this look legit? I'll make them fiasp if they're not. Trust.
but no, it's just one of those areas where it's just sort of good being careful, because you're paying over good money for it.
Yeah, and very, very often a lot of money. I mean, the standard rate for clinical psychology is about £100 an hour. Now because I work and I live in this community, my rates are lower, so I do £85 an hour and £70 for students. But I think that's because I've been embedded in the community for a really long time, and I also work for the NHS, and then somebody would probably come along and like rap my knuckles and say, value yourself more. But actually, like I love this community, and it's the reason I do all of what I do. So and I'm sure that there's probably others like me out there as well who will do maybe like a sliding scale. So like if you
Yeah.
can't afford therapy, if you can't afford therapy but you find a private therapist, it's always worthwhile approaching them and saying, do you do anything pro bono, or do you have a sliding scale?
Yeah. And seeing what's out
No,
there.
we don't ask, don't get, right?
Yeah. No, I work on that theory as well in life, Jack. So thank you so much, Jackie. It's been really, really interesting.
Philip, you just called me Jackie again.
I didn't. I said Jack, didn't I?
No, come on, everybody clap.
No.
Thank you. Thank you very look.
No. I'm so sorry. I'm
You're
useless,
triggering me.
Jack.
That's 2 pips that you've deserved now, Philippa. or a double gin and tonic. Your choice.
I'll get you the gin and tonic, Jackie. Jack.
That's it. Treble.
That's 3. You'll be too drunk to realise what I'm calling you after
Oh,
that.
never. I'm Scottish. That's breakfast. Oh, for anybody that employs me out there, I didn't just say that.
One of my problems is one of my close friends is Jackie, and so you know how it's just natural to say it.
No, Philippa, I
Jack,
don't.
we just have one more question coming from Tempe. Wants to know when you're coming back to tell us more.
Oh, well, I don't know, whenever you want. I feel like this is all, the problem is it'll always devolve into trauma, because trauma in type 1 is kind of like a special interest of mine, just in case you couldn't tell. But I'd be happy to come back and talk about different forms of therapy. Dialectical behavioral therapy is quite cool. Also being used a bit more. And EMDR is something that's coming up quite a lot, although I'm not trained in EMDR yet. But I'd be happy to talk about it because it is quite cool. Whenever you want, really.
Oh, we shall have to book you in at some point. We'll be in contact, Jack.
Definitely.
Yes, thanks, Philippa.
I apologise. I do apologise.
It's all right. I'm only messing.
No, I know, but I still do apologise. Well, thanks ever such a lot for your time. It's been really interesting, and I think for the comments that I've sort of was reading through, people have been really interested and found it really useful. So thanks once again, and hopefully we'll talk to you again at some point.
Thanks very much, Jackie. It's been really helpful.
You're so welcome. It's a pleasure to be able to do this and to sort of hopefully spread my passion for diabetes psychology.
Yeah, and I think it is one of those missing areas. I know it's becoming more, but I think just getting it out there and normalizing it.
Yeah, diabetes is relentless and it's hard. It's hard and it's relentless and it's stressful, and and it's all of that on top of everyday life, which is relentless and hard and stressful. So
Yes.
So of course you need diabetes psychologists. I mean, it's a literal no brainer, pun.
Yeah. No, that's great. All right, well, we can open it up to other people. Has anybody else got anything to say or comment on what was covered, or some other different topic?
And just don't forget that if you have got any problems, to talk to your healthcare team.
Yes. There are services.
Thank you once again, Jack, before you go.
That's all right. I'll hang around if anyone's got any questions or anything.
You'll be doing full-on therapy sessions with all of us, Jack.
Absolutely not. I need my own. I'm triggered after you called me Jackie. I need my own therapy.